All right. Parsa, Chris, thanks for being with us this morning. We're here to talk about an extraordinary AI-driven system called PALM, which is now operating at Montefiore Health System in the Bronx, a huge hospital complex, and all of the neat things that it does. But before we get into kind of its capabilities and how it works, to the extent we're going to be able to understand that this morning, I want to just talk about how did this partnership come about, and what's the sort of size of the investment? Who had the idea? Give us the origin story of this.
Well, it was a long time ago, so I may have forgotten some of the very specifics, but like many of the partnerships, it grew organically. Montefiore is one of the most wired hospital systems in the nation.
So when you say it's one of the most wired,
it means we use digital technology and computations all over Montefiore enterprise, from patient care to operations to administrative systems. They're all digitized. Inpatient, outpatient, ancillary systems. We have one of the most robust electronic medical record systems, which basically means to you that we have a lot of infrastructure, data centers and compute, which mostly are based on Intel architecture. So we see each other very much. We work together on many grounds. Back in 2014, the notion of using our data assets as part of our business practice, not just as a cost center for the hospital, became a strategic motivation at Montefiore. So we were starting to think about what would be the architecture like. I think one of the previous panelists mentioned that to have the best AI, you should also have the best IA, information architecture, which is true. So we started thinking about what would be the architecture, who would be in the best position to partner with us to imagine the future of delivery of healthcare based on data and analytics. We talked to our partners, Intel being one of them, and I think it made sense to collaborate. It is like dance, quite honestly. You take a move, your partner takes another move, and before you know it, you're engaged in an elaborate dance. And we've been really successful in getting to know not only the technology and what technology offers and what is possible, but also each other in terms of how we can work together towards a very long objective. It was 5 years ago, and we are still not even halfway through in terms of really seeing the benefits of our investments. So you have to be prepared to do the long game, and to have a partner that can come with you.
The vision that Parsa and Montefiore had was very ambitious, bringing together many different kinds of data that are electronic in the healthcare industry, not just data from the electronic health record at very large scale. And so Intel, being a data company focused on moving, processing, and storing data, we thought that our capabilities would be a really good match to assist with that, bring that vision to reality.
Yeah, that's very true. I mean, let me just explain that a little bit. When we say data, what it means in a hospital system like Montefiore. We are a large health system, 11 to 14 hospitals, depending on who you ask. And we cover the entire spectrum of delivery of care. We collect data from our EMRs, which is pretty much structured and semi-structured data. We collect a lot of free text, notes taken by doctors, nurses, patients' own narratives. We take a lot of images, as you may know, MRIs, CT scans, X-rays, bone scans. We take pictures from all over the body, from your retina. We take pictures from your pathological samples. Huge amount of variability, waveforms. We measure the electrical activities of heart and brain. Every room you walk into inside the hospital has a lot of monitors and sensors and detectors that collect a lot of streaming data. So we really collect a lot of data about patients as they walk inside the hospital. And then our patients go home. And we get to know our patients as they live their lives at home. We know their places of living, whether or not they have access to proper food, proper health facilities in their neighborhood, what supermarkets they have, what transportation facilities they have in their houses, what is the property like in the locations that they live, the quality of the air in the neighborhoods that they live. So we really need to know our patients very well in order to be able to cater the kind of high quality care that we are supposed to be doing. And it's all based on the data, and we really have to wrap our head around how do you maintain that data, how do you put it together, how do you understand it the way humans understand it, and how to use it. So it's a very complex data environment.
Just to give us a sense of where the rest of the industry is and how kind of state of the art this is. You just mentioned, off the top of your head, some 25 or 40 really data streams that you all are collecting, down to social data about your patients, about where they live, et cetera. And all of that is digitized.
Most of it is.
Most of it is digitized. Where are other hospital systems in it? Like, what portion of it is it on paper for kind of the median hospital in America?
So it is a curve, you can imagine. We are in a much better place than we were 10 years ago because of a lot of regulatory aspects, meaningful use, which was part of the Affordable Care Act, really helped with adoption of digital technology in hospitals, and it is getting better. Most hospital systems are realizing that now data is an asset, not just a cost, and not just for protecting yourself in the case of a lawsuit, but also a big strategic aspect of your operation now.
Sure.
So they make investments on collecting this data in more digital format. It doesn't really matter what we think. The world around us is also changing. Every thermometer we buy today collects digital data and attempts to talk to your phone, even before you ask. Internet of Things. So every single piece of technology that is coming out these days is equipped with collection of the data and communication of data in a format that you can actually capture and use it. So the world around us is also changing.
Digitizing the data is really only half the battle, right? So if you look at the standard in the U.S., yes, most health systems, most doctors are on an electronic health record. Most doctors use electronic medical images, or all do. That's the PAC system. But these different systems in the hospital are siloed. One system could even have multiple medical imaging systems and multiple different electronic health record systems that have difficulty interoperating. So what's novel about this is bringing all these siloed data elements together in one platform that's designed from the ground up for analytics, being able to fuse together these different, all the different data streams that Parsa mentioned, to figure out how are these connected and how can they be used to improve patient care for this specific patient. So that's very novel and groundbreaking.
And are you seeing? I want to talk about some of the applications in a minute, but are you seeing, like, has this been a real proof of concept for you all, and now are other hospital systems jumping in and being give us that?
Yeah, I think what you see is, especially with some of the more advanced health systems, a lot of them are very interested and at some level of adoption for predictive analytics, using the data to predict what's going to happen. But they're sort of, as one of my colleagues in the system or health industry said, islands of excellence. So you can sort of shine a spotlight on this one use case at this one hospital that could maybe predict which patients are at risk to be readmitted for the same condition back into the hospital the next 30 days. But there's, a million or hundreds of thousands of models that you really need to put into production to move the needle in healthcare. Sure. And so here, it's really about that scale. How can you have that foundational platform to deploy a wide array of use cases and really change the cost curve and improve outcomes? So.
Well, let's talk a little bit about what this POM system has enabled. What sort of predictive work is it doing? What can you give examples from specific patients that have been helped by the system?
So the PALM stands for Patient-Centered Analytic Learning Machine. So all of these varieties of data that I just mentioned, somebody needs to center them around the patients. So as a system, we know everything that there is about our patients before even we try to do any analytics about them, right? So one aspect of Palm is that fusion of all of these data around patients, so we can really know everything there is to know about our patients. What are their risk factors, where they live, what they do, what happened to them last time that they were here, their family history, everything in one, through one lens. And make it available to many, many analytics that we are going to build in the future, so they can see the same patient. They can see the holistic view of the patients, all of them. So they all have a shared understanding of what the patient is, rather than fragmented. I'm a cancer detection algorithm on imaging. I'm just going to look into this image, and I have no idea about patient's history, or patient's family history, or their past exposures. We want all of our analytics to have the same view of patient information, and be able to talk to each other. A risk model in outpatient should be able to inform another risk model in inpatient setting, and tell things that this model needs to know that has happened to the patient in an outpatient setting. So the coordination across all of the data around the patient, and all of the analytics that are running around the enterprise around the patient, is what Palm does. Creates this holistic view of the patients and collaboration between multiple models. I think Chris asked a really good question of how many models do you think a healthcare system needs to develop in order to understand millions of patients coming from different walks of life, having many, many different problems in order to coordinate their care. And it's not just the clinical aspect of the patient, it's operational aspects, all of the administrative delivery of care and care coordination aspects that needs to be, it is literally millions of models. I'm talking about future. Today we have probably dozens, and we are still in trouble. Just imagine what happens then when some models say, turn left for the patient, this best thing to do is go this way, and the other model says, no, turn right. You can't do that in healthcare.
And getting into the specific use case, for example, for those in the room who may not be really close to the health and life sciences industry, healthcare is very reactive. They wait for something to break and they try and fix it. A very minuscule percentage of the budget is spent on prevention. The reason why these models or use cases are being deployed is to really help the healthcare industry or a specific health system to become less reactive and more proactive and predictive, figuring out which patients are at risk for example, needing to be intubated. I think that was the first model or use case that was deployed. Because once a patient's intubated, as Parsa can explain better than I can, the chance of a good healthcare outcome are reduced drastically. So if you know that across your entire population, this small number of patients is at very high risk of being intubated, then you can intervene to try and stop that from happening and improve the outcome and reduce the cost, improve their prognosis, right?
Sure, absolutely. With respiratory failure, patients stopping breathing is really dangerous, you can imagine. So we would like to understand that before it happens. When that happens, first you intubate the patient, put a tube in there to breathe for them, put them in a mechanical ventilator so the machine breathes for you, and then you take patient to ICU, which is the most dangerous place on earth, literally. No one wants to be there. You have to get the patients out of there as fast as possible. But guess what? When you're intubated, you're going to stay there for days. So anything you do to prevent from intubating patients and avoiding going into the ICU or shortening the time that you're going to stay in ICU is a lifesaver. So we started with literally saving lives by predicting patients that will require mechanical ventilation 48 hours in advance of that event happening, to prevent patients from going into the ICU, and also predicting which one of those patients will eventually pass. They will die inside the hospital. So if there is really nothing that you can do, you can at least start going into the end of life care and communicating with patient's family to prepare them. So you can actually start being more proactive rather than reactive to some of those things. And since then, we have seen that these kinds of methodologies not only can help with the better care outcome, but also more humane care, because you can communicate with patients in a much better condition. When you have a tube in you, it is really difficult to make decisions and to do the right thing, to even understand information that is given to you.
Yeah.
When you have a couple of days to think about it and participate in your care, and your family has time to also think about things that might happen, and make the right decision with the right information and the right time, that actually helps a lot with.
I want to go to an audience question or two in a minute, but before I do that, tell me, at a time when people are increasingly concerned about really central stores of data, when hacking is ascendant, when the federal government's personnel files have all been hacked by the Chinese and whoever knows else, how are you thinking about information security, given that you are storing this, as you say, really holistic view of a patient? Sounds great from a care perspective, but terrible from a privacy perspective.
I mean, I can start with that. So, healthcare industry has some of the most restrictive regulations around privacy, far more so than most industries. So, for example, if there is a breach, there is, by law, the system is required to report that breach to all the patients that are affected and the local news outlet. So there's fines associated with it. So there's a lot of motivation above and beyond just doing right by the patient, protecting privacy. But typically in these large platforms where you're doing the research and developing the models, you're operating on de-identified patient data. So you can strip out some of the identifying characteristics to do that processing. So I would say it's definitely top of mind across every health system I talk to. Every chief information security officer wants to do everything they can to A, meet regulations, but B, prevent a breach from happening for those reasons.
I think we should separate notions of security from privacy. Healthcare historically is very sensitive to both. In hospitals, we have literally military-grade security, and it's a moving target. I mean, hackers get smarter, we have to get smarter as well. And we are also controlled by a lot of regulatory, so it is not free-for-all. Now that data is there, everyone can use it for every purpose. Every single access to the data is regulated and coordinated. And then, as Chris mentioned, we have processes to protect data. For analytic use, you don't really need to know who the patients are. You just need to have access to the patient. So we have de-identification processes that enables us to analytically use the data without knowing anything about who these patients are individually are. So your algorithm gets trained and gets better in recognizing patterns without having to really understand who this specific patient is. But at the delivery of care, at the point of care, you need to know who that person is, and the algorithm gives you a score, or it tells you something that a provider or a nurse that is talking to the patient can personally understand. Okay, so this is about Mr. Smith. So we have processes to deal with both security of the data and privacy of information as we use it for training the analytics or using the analytics in the point of care.
I want to finish up with a question from Mike, who asks, will AI replace most doctors in the next 20 years? And are some specialties more subject to this disruption than others? I'm sure you get this a lot.
So I think one foundational starting point is that the industry is, you could argue it's broken today. It's not like we're in this sort of nirvana situation. We are facing a caregiver shortage. For the first time in human history, there's more people over the age of 65 than under the age of 5. Where I view AI is really providing a boost to address that challenge, address that clinician shortage, and A, improve what's happening today, and B, offload some tasks that can be automated to machines. but it's always going to be very important for humans to be in the loop in providing care and providing that touch to the patient from a comfort level, from an expertise level, from the perspective of verifying predictions that the software, the clinical decision support systems may be making. So I don't see a widespread replacement in the next 20 years of doctors. I see it as addressing some of those foundational challenges that exist within the industry.
Great.
So can I?
Yeah.
I think the question is not being asked in a right way. I don't really see it as a notion of replacing anyone. If the question is, will medicine change? The way we think about medicine will change because of AI or analytics and data-driven processes. The answer is absolutely. It has already started changing. So what we understand about radiology and imaging today will be completely different tomorrow because of our access to these kinds of technologies. Then the question becomes the radiology process that we have today, is it even appropriate to maintain? Right. Or should we train a new generation of radiologists that are enabled by these tools that can interpret not just the images that we take at the tissue or a person level, but also cellular level and pathology level, and integrate pathology and radiology into integrative imaging? Which is now something that we couldn't do yesterday. Yeah. We can't do it even today, but with the technology we'll be able to do tomorrow. Maybe that is the way you do radiology. So if you can accept that medicine has never been the same thing, if you go 50 years back, we didn't have radiology, we didn't have x-rays, we didn't even have this entire field of medicine. We now have that field will transform to something else. We'll probably our nursing has changed because of these analytics. They are now engaging in patient care that is driven by models and analytics rather than doctors. That is a change. We didn't replace anyone. We changed the way things are done. And that's going to be, from my perspective, the radiology of the future, pathology of the future. Those are those two things that people are worried about being replaced. If we can accept that, I think that's actually a very good thing if it happens.
All right. We end on a bit of good news. Chris, Parsi, thanks for being with us today.
Thank you.